Hello, my name is Dao. Today I will be presentations about red blood cell transfusion therapy in sickle cell disease. These presentations will cover the effectiveness, risk, and complication of red blood cell transfusion therapy in managing sickle cell disease. For patients with sickle cell disease, usually vaccinations and penicillin are essential for preventing serious infections in patients in sickle cell disease. Red blood cell transfusion is a critical part of sickle cell disease management, helping to reduce both morbidity and mortality. Is required by approximately 90% of adults with sickle cell disease. Opioids are used to manage the severe pain crisis. Red blood cell transfusion are especially important for preventing and treating major complications such as primary and secondary stroke, acute chest syndrome, silent infarct, and preoperative management. Transfusion therapy offers a significant benefit, particularly in managing pain episodes for patients with conditions. Research also indicates that those receiving regular red blood cell transfusions experience fewer vaso-occlusive crises compared to those who do not. This makes transfusion a vital treatment option for pain management. Additionally, a randomized controlled trial highlighted the advantage of preoperative transfusion in maintaining hemoglobin level can effectively prevent complications during surgery. Hydroxyurea is one of the medications that sickle cell patients usually use to prevent formation of sickle cell. It's important that transfusions have been found to be more effective than hydroxyurea in preventing recurrent pain, leading to shorter hospital stay for transfused patients. We have two types of transfusions. Simple transfusions involve infusion donor blood without removing patient blood, indicate for acute anemia, acute chest syndrome. It's the same with other like regular transfusions in patients. However, it carries risk for volume overload and iron overload. In the other hand, red cell exchange involves removing the patient red cell and replacing them with donor cell. It's red cell exchange provide better control of fluid balance and hemoglobin S level. It's preferred for acute ischemic stroke and severe acute chest syndrome. Studies also show that red cell exchange do not increase alloimmunizations compared to simple transfusions. Even red blood cell transfusions is helpful for sickle cell patients, but also have complications such as infection rates, iron overload, allergic reactions, alloimmunizations, hemolytic transfusion reactions. For iron overload from red blood cell transfusions, which can damage patient vital organ like heart, liver, and endocrine gland, often leading to death from cardiomyopathy. And regular screening with liver MRI every 1 or 2 years is recommended for transfused patients with sickle cell disease. Treatment involves iron chelation therapies using 3-lysin chelator. It's the dexfurosemide, dexfuroxyrox, and dexfuroprone. With the dexfurosemide administered by subcutaneous infusions, careful monitoring and side effects, strong adherence to therapy, and insurance access to chelation treatment are crucial for successful management. Red blood cell alloimmunization is a major complication in transfusion therapy, especially for sickle cell patients due to high transfusion blood and Rx genetic diversity. Study shows increased risk with more transfusions, but automate red blood cell exchange may reduce allo antibody formations. Allo antibody can shorten the red blood cell survival and cause delayed hemolytic reactions. Immunosuppressed therapy is recommended for high-risk patients. To prevent alloimmunizations, red blood cell antigen matching is crucial in preventing and extend red blood cell antigen profile, including ABO, RXD typing, and typing and matching for specific antibody. Despite limited post-transfusion testing, establishing red blood cell phenotype and prophylactic matching for PIK-CE and CAL antigens significantly reduce alloimmunization rate is because the frequency of PIK-CE and CAL are higher in blood donor populations and leading increased risk of alloantigen exposure with red cell transfusion. The age of red blood cells significantly influences alloimmunization too, which is the formation of antibody. Again, transfused blood. Red blood cell can be stored up to 42 days, but during this time they undergo change that affects their functionality, known as storage lesions. The alterations can lead to increased risk of antibody formations in recipient. This is crucial for patient safety, and higher antibody level can complicate future transfusions and increase the risk of inflammatory response. Hemolytic transfusion reactions like we know that involve accelerate destruction of red blood cells. Acute reactions occur within 24 hours, usually due to incompatible red blood cells, and delayed hemolytic reactions happen after a day, caused by immune response to donor red blood cells antigens. A little bit about delayed hemolytic transfusion reactions as significant risks in transfusion therapy, primarily caused by alloimmunizations. These reactions are often underestimated and underdiagnosed in patients with sickle cell disease, as their symptoms can be the same with the vaso-occlusive crisis. With febrile non-hemolytic transfusion reactions, a significant event that can occur during blood transfusions. The reactions are primarily characterized by the onset of fever without any hemolysis. A common symptom is chill, tachycardia, anxiety, headache, hypertension, and discomforts, typically manifesting within 4 hours post-transfusions. Diagnosed Febrile non-hemolytic transfusion reactions often involve ruling out other causes as they can stem from both immune and non-immune mechanisms. For immune mechanism occurs when recipient antibody react against donor white blood cell antigens, and implementing glucose reductions can significantly lower the incidence by removing these cells associated antigens. On the other hand, non-immune febrile non-hemolytic transfusion reactions can are linked to cytokine release from white blood cells during storage. Last one is allergic transfusion reactions. Usually manifest as rash, pruritus, wheezing, or angioedema. Mild reactions include a slight temperature increase or localized rash. Early symptoms may resemble severe issues like sepsis or anaphylaxis, requiring immediate discontinuations of transfusions. This is all the site that I use for this presentations. Thank you for watching. If you have any questions that need to ask me about the sickle cell transfusion in sickle cell patient, please comment and then I will be answered. Thank you.